Thank you, Cameron. What a great way to open day two. And we're going to kick off with one of the biggest discussion points in the world at the moment, and it's AI. And I spend a lot of time in the social media space, and it's hard to know now whether a post has been written by a computer algorithm or a person. Not even just social media posts, but essays and books. You just don't know who's telling you what's going on. And we've got just the man to talk to you about it. He is Kevin Fong, a consultant anaesthetist at University College London Hospital and a pre-hospital doctor with Air Ambulance Kent, Surrey and Sussex. He recently hosted the brilliant BBC Radio 4 series, The NHS, Who Cares? And his reach is impressive with over 40,000 Twitter followers, although I could say he's not trying hard enough because I've got a few more. But coming back to Twitter, the hashtag for today is this in capital space 2023. Get on there, tag it, share it, let us know what's going on. In Kevin's talk, he's going to explore why it's so difficult to predict the changes that will come with AI in healthcare and why we really need a generalist workforce to manage those changes that come from the technology. Remember, put your questions in the chat box or I'll be fangirling him in the panel for 20 minutes and you really don't want that. And now let's hear from Kevin.
Hi, I'm Kevin Fong. I'm a consultant anaesthetist at UCLH, and I'm being asked to talk to you today about my thoughts on future workforce, which actually I gave a lot of thought to and decided that it was quite hard to predict, and I can explain why. Let me start with this. So I know that you'll want me to speak about AI here. But I think that it is very difficult to understand what the implications of AI are in the workforce, and I can try and begin to explain to you why. Put my slides on. Okay, there you go. So there's AI, and it's all the rage, and everyone's talking about it. But I think that this is going to be extraordinarily difficult for us to predict. And so when we think about workforce, I think we need to think of some different things, which is how we best equip a workforce going forward to deal with what I think are going to be some very unpredictable changes that will come with AI in society in general and in healthcare as well. To give you an impression of just how quickly things move with respect to technology in the average lifestyle now, we should look back over the last 100 years or so, or just over. This is Jean Calment. She was born in 1875. She's the oldest woman who's ever lived. When she was born, the average life expectancy across the world was in the fourth decade of life for men and the fifth decade of life for women. And that was because of infectious disease and massive infant mortality. Jean Calment lived from 1875 to 1997. She was 122 when she lived. This is only her 117th birthday, so she's got another 5 years to go when this photo is taken. She's old enough to remember Van Gogh walking into the bakery in the town of Arles when she was a young girl. As she lived through life, she would have watched society transform beyond all expectation and all recognition. And really, the story of her life is the story of rapid change, born on the wave of successive waves of technological and industrial revolution. So in 1905, this is manufactured. It's the first production stopwatch. It's the Tag Heuer micrograph. It can measure time to a fraction of a hundredth of a second. And the reason that it comes into production is because before this, there was no event that was worth measuring to that accuracy, but this is the dawn of the internal combustion engine and motorsport, and so now people are measuring things with stopwatches. And I say all of this because the general purpose technologies of the 20th century were internal combustion engines and electricity, and even those managed to transform the 20th century in ways that certainly Jean Calment growing up could never have imagined. Now, there are penalties for not being able to see the future. There are problems. Things don't stay the same. I grew up in a town called Harrow. I was at school in a place called Wealdstone, and in Wealdstone there was a Kodak factory. That's it in the top right of this slide. And that's where a lot of the people who left that school went to work in that factory because it was a very good employer for the town. And we thought it would be there forever. It made film and photographic paper. But you can see in the bottom left there what happens to it, and the bottom right. So stock price plummets at the end of the 20th century, and that's because digital photography comes in. Now, Kodak, as a manufacturer of film and photographic paper, cannot see the future coming, and so it destroys its business model. A similar thing happens with Nokia, who at the start of the 21st century are market dominant. You can see this slide now showing their global market share from 2007 going forwards. And in 2007, of course, everyone had a Nokia mobile phone. But by 2013, they've lost most of the global market share. Now, in both cases, these are organizations who should have seen the future coming. Kodak manufactured film and paper, but more than that, well, Kodak manufactured film and paper, but its business model is destroyed by digital photography. But digital photography was invented in 1975, and it was invented by Kodak, by an employee of Kodak. And yet they were unable to see what was going to happen in the future. The same thing happened to Nokia. Nokia are an information technology company. They build mobile communications devices, and they cannot see what's going to happen to the landscape. It's very difficult to predict. This is actually a slightly jokey slide about how phones got smaller and they got bigger again. But that's the point, and this is the mistake actually that Nokia really made as a company, which was what you're seeing here is not phones getting smaller and larger again. What you're seeing is a discontinuity boundary where mobile phones stop being mobile phones and start being mobile computing devices. And so the whole point here is when you're looking at the future, you have to look at how unpredictable the past has been. And that partly is a product of the exponential rate of technological advance in the 20th century. And we're following that now. And in fact, AI even more so, because its rate of advance is coupled to the exponential rate of advance of processing power. So Jean Calment lived across a century that was faster than ever before, and the time in which we live is unique because of the pace of technological advance, which makes predictions about what the workforce is going to look like, what healthcare will look like in the future, very difficult. In the time that Jean Calment was alive, we went from a life expectancy of people's life expectancy having been for almost all of human history in 30s and 40s to being almost double that by the end of the same century in which she died. In that time, we had antibiosis, we had immunization, we had organ transplants, we had intensive care, and the list goes on and on and on. And so healthcare became something that had never been before in a few short decades after her birth. We can really expect the same pace of advance as we go forwards in the 21st century. And if the end of the 21st century is as different from its beginning as the end of the 20th century was different from the beginning of the 20th century, it's going to be very hard to imagine how all of that is going to look. So what does that all mean for the way we plan a workforce? Well, from my point of view, I think it means that you need well, first of all, for a future workforce, you need a workforce. And more than that, you need a generalist workforce that is able to pivot and face new challenges as they arise. Now, at the moment, we have a real problem with recruitment, retention, and well-being issues in our workforce. And for me, before we start any conversations about what the shape of that workforce should be going forwards, we should think about how we retain that workforce. Now, that's not just because that's the most important problem to face. It's because effectively going forwards and building the future of healthcare requires you to have sufficient organizational memory to be able to understand how to shape future needs. And at the moment, it's not clear to me that that's the case. As you can see from these two graphs, both of which are sourced from NHS digital data and from Nuffield Trust's analysis of those data, at the current time, we have the highest number and proportion of nurses leaving the service, both in absolute terms and as a proportion of the workforce, since records began in 2011. And we're seeing that nurses are leaving nearly as fast as they join. Now, the good news is that we have more nurses in absolute terms than we've had before. The bad news is that there's massive churn. So we're not retaining our nursing workforce, and we are recruiting, training, and then losing a large fraction of our workforce. And that doesn't allow us, when we're pursuing quality improvement projects and when we're pursuing projects that are going to help us design how we are in the future, losing your staff at such regular intervals doesn't help. Now, COVID-19 is not the cause of the poor well-being of the workforce, but it did unmask, I think, problems that have been hiding in plain sight for a long time and at least brought them to the fore. These are two papers that were published by groups that I worked with during COVID that looked very strictly at the staff who worked in intensive care during COVID-19. But I think that you can fairly extrapolate many of the findings here to the broader workforce. And indeed, there's a lot of supporting literature that suggests that the wider workforce, both outside of intensive care and outside of the hospital setting, also suffered quite significantly during COVID. I'm just going to overview the results of the second of those papers, the British Journal of Anaesthesia paper, because the results are startling. So we surveyed people who worked in intensive care over about 6 different time points at about 6 to 8 week intervals during the pandemic. And the BJA paper, the British Journal of Anaesthesia paper, was published with 3 time points before the January 2021 wave, during that wave, and after that wave. We used standardized questionnaires to assess their generalized anxiety disorder, a measure of depression, a measure of harmful use of alcohol, and also PCL6, which is a standardized measure screening for post-traumatic stress. This wasn't a small study. We had over 6,000 respondents here, and in each single time slice, several thousands of respondents in each time slice. The summary is this: it's pretty startling. Rates of severe depression, suicidal ideation, and severe anxiety were extremely high, but a particular note was the rate of probable post-traumatic stress. Now, that number came in at 46.5% across all of the staffing groups, with the nurses worse affected than the doctors. So the nurses peaked out at 54.8%. Now, you can cast that in sharp relief, I think, with the next slide, by comparing that headline rate, so the peak rate here, as I said, of probable PTSD, so in this orange line. Possible PTSD is blue, that rate is higher, but probable PTSD, which means that the screening tool has a higher chance of correlating with an actual diagnosis of post-traumatic stress, peaks out at about 46.5% there. Now, prior to these studies, using similar measurement tools, the highest rate published anywhere in the literature was in British military veterans who had served in a combat role in Afghanistan, and that rate was 17%. So it's difficult to compare between populations, and it's difficult to compare between specific circumstances, but in absolute terms, you can see that these numbers are really quite worrying. And it shows, and the other thing that you can see from this slide is that the workload stress seemed to correspond with the severity of injury amongst these people. So this is telling us something that I think we probably knew at heart, which is the greater the intensity of the workload, the harsher the working conditions, and the worse the perceived well-being of the staff is, as reported in their mental health symptoms. Now, why is this important? Well, if you want a future workforce, before you start to think what that workforce should look like, you need to be able to keep them, and they need to be able to function well. The first point is that poor staff well-being seems to equate to poorer patient care. How do we know that? Well, we added a measure of their functional impairment during COVID with the Work and Social Adjustment Scale, which measures how likely the respondents feel that they are impaired by their state of mental health. And on that scale, we found, as you can see, more than 70% of the staff believed they were highly likely to be impaired in their professional tasks, or probably impaired in their functional tasks. So poor well-being seems to go hand in hand in this study and in our study in the BJA, but with Rona's work with previous screening tools looking at post-traumatic stress in particular. And so poor well-being is important, not just because of the injury it's causing to staff, but also because of the potential poorer performance they have in the workplace. Poor staff well-being also costs money. And again, if we're looking towards a future health service and the shape of it, you need sustainability above everything else. There's no point in designing it if it is not sustainable in the first place. Now, if that workforce isn't being retained well, and if the poor well-being amongst that workforce is costing you money, it becomes less sustainable as a service as a whole. Healthcare is a labor-intensive industry, and higher costs and poor retention and high turnover, none of that is going to be cheap. We studied this, we reviewed this with a rapid review with the International Public Policy Observatory, where we looked at the long-standing evidence that suggested that poor staff well-being may cost money, and whether or not investing in staff well-being may help. So what did we find out? We found out that 47% of staff reported feeling unwell as a result of work-related stress in the previous 12 months, and that figure worsened in the 2022 survey. Sickness and absent rates for NHS staff in England was at 5.7% and has since increased in the most recent survey. And this all correlates with high vacancy rates, high turnover rates. Many studies show that poor NHS staff health and well-being are correlated with reduced quality of care, financial performance, and patient satisfaction. So again, what we're looking at here in our failure to address the well-being issues amongst the workforce is the threat of poor sustainability going forwards. What is the cost of all of this? Well, using fairly conservative economic models here in the IPPO study, we found that it was around 12 billion a year, and that's accounted for in recruitment costs, agency and locum costs, and presenteeism. And that by eroding that by 5 or 10% a year, you could save up to £1 billion in some of the scenarios that we modeled. So it is in everyone's interest that we address this before we try and move forwards into this brave new world. In summary, poor workforce well-being of the workforce threatens the quality and safety of patient care, threatens retention of staff and the continuity of the service. And to solve it, we need both secondary and tertiary support for people who are already feeling unwell, but also we need prevention. Prevention here, like everywhere else, is better than cure. Currently, we need to recover our existing staff so that we can recover the service as a whole. I think we haven't yet done that, and I think that we won't be able to continue to ignore that. Poor staff well-being is also a strategic threat. It's very obviously an operational threat, because if you don't have enough people on the shop floor, you cannot continue to prosecute your service. But it's also a strategic threat because the high turnover of staff leads to a loss of organisational memory. And you get into these self-reinforcing feedback loops, which leads to a very unsustainable working pattern. Again, no workforce, there is no future workforce. So designing a future workforce is about designing sustainability. Poor staff well-being leads to higher absence rates, poorer staff retention, shorter staffing, which then leaves a higher workload for those who remain, and that feeds back on itself. And this is a very destructive feedback loop. Just at the end here, going to suggest a way forwards. And the reason I've focused on well-being in my discussion of future workforce is, as I say, because if you do not have a sustainable workforce, everything else is for nothing. You can't start to design the future without out of sight of the workforce. Now, my feeling in all of this, since I've been looking at it, is that we have spent an awful lot of time looking at the technical aspects of the complex system that is healthcare. But the system is social and technical, and I think we have massively ignored the social component. In fact, the only way that we usually engage the social component in the design of healthcare systems is usually as this invisible buffer that compensates for problems within system that haven't been anticipated by system architects. The problem about that social resource is it's not inexhaustible. And we see that all the signals we are getting, which have been hugely unmasked by the experience of COVID, tell you that this is an exhaustible resource, and indeed it is exhausted. Record leaving rates amongst nurses, poor retention, very poor well-being. And if this continues, we will not be able to expand the workforce and keep it sustainable for future needs. Now, I referred there to the focus on technical. We're good at technical, actually. I work with a helicopter ambulance service, and I work as an anaesthetist. All of these items I work within or with, and every day I go to work, I or somebody else checks them thoroughly to make sure that they are functioning and to make sure that they will function when they're needed. Now, no one does the same check on the staff on an operational basis. There is no regular check of frontline healthcare staff that assures that they are in good working order and that they are fit for purpose and that they don't need to be given a rest so that they can recover. So when it comes to planning a future workforce strategy, what does good look like? We do not know what the future is going to look like. The first half of this talk was telling you how difficult it is to anticipate how technology will shape the way that the world looks. We can make some guesses, but we really don't know. The 20th century brought a variety of complex risks that we hadn't anticipated, that we had to adapt to and reposition ourselves as health services to meet, not least COVID most recently. A future workforce strategy is one which sustains the workforce, that provides a generalist workforce that stays with you long enough to gain enough organizational memory to prosecute the programs of improvement and development and innovation that are required to drive the service forward. How do you do that? Well, one, you make well-being central to your organizational strategy. It isn't at the moment. It should be, because the human element of these socio-technical systems is being long ignored, and clearly we are paying the price for it at this time. The second thing you do is measure. You don't manage what you don't measure, and we haven't been measuring well-being on a basis that is operationally useful to people on the shop floor. And you manage that workforce because by taking note of the impact to the workforce when we make system changes and innovations. We usually reform services and innovate services without much thought for the workforce impacts. And again, I think that has been part of the problem of the erosion of the well-being of the current workforce. You don't manage what you don't measure, you don't respond to what you don't regulate. And so this should be part of our regulatory frameworks going forwards. The regulators have an important role here as a lever to encourage better care of the people who care for our patients. And of course, none of this is free. We mustn't make the mistake of thinking that good well-being is cheap and about just attitudes and culture. It, of course, requires investment, but I mean investment rather than expenditure. If you spend this money properly, you should expect to see it again. Finally, and for me most importantly, good looks like co-creation. And co-creation is all important here, and where many of these initiatives, I think, fall down. COVID is part of the problem, or at least has exacerbated the problem here, but it also suggests part of the solution. During COVID, frontline operational teams were broadly facilitated to manage their own problems at source in leadership that was less command and control and more facilitative. When it comes to well-being, the leaders at operational level probably have a better idea about what they need than we can at the most senior strategic tiers. And so co-creation of the solutions to well-being is probably important if we're going to get to the right decision. Co-creation really of all the innovations going forward, of course, is important, but co-creation of solutions to their well-being is probably the most urgent of those. So in summary, this has been a talk about the future of the workforce, but probably not from the angle you might have expected. I think the way that AI is going to change the world and our practice in the 21st century is impossible for us to imagine over any useful timescale. Many promises will be made, and it will have some advantages and some disadvantages. To be able to manage all of that, you need a generalist workforce that can be adapted and pivoted to face whatever the emergent advantage or threat that comes from that technology. And to do that, you need to have a sustainable workforce that is going to be there and gain enough organizational memory to help move you forward strategically in the most appropriate way. Thank you.
Thank you, Kevin. Wow, that's really food for thought. And I love what you said. You can't look at the future unless you fix what we have at the moment. And we've had so many questions coming in. And as you can all see, an amazing panel of people to talk. Joining Kevin today, we have Mary Dixon-Woods, who's the director of this institute. We've got Kiran Patel, who's the Deputy Chief Executive and CMO of the University Hospitals Coventry and Warwick NHS Trust, and Professor Alison Leary, a Professor of Healthcare and Workforce Modelling at London South Bank University. And I'm just going to kick off with the questions. Alison Powell has asked, staff who are under the most pressure are the least likely to find time to participate in research. How can we ensure that healthcare improvement research includes the perspectives of the busiest members of the workforce? It's tough, isn't it?
Well, I guess I'll kick off. I mean, that all comes to what I was saying, which is effectively the adaptive social component of the system as we have it is the one that we need to invest in. And unfortunately, in recent years, because of, I think, the mismatch between supply and demand, we have come to regard it as service provision in the main. The first thing that goes whenever you're under stress like that is the training budget, and because that is seen as less important when in fact it is essential. So yes, hard agreement. The point is that we should be investing in that, and the workforce of the future is one which has that seen as time that is as important as the time you spend delivering service.
Thank you. Anyone else want to comment?
Yes, Liz, I'll come in if I may. So I think research is really important. We know research active organisations deliver the best patient outcomes, and therefore we need to engage the entire workforce in research. For me, that means driving a culture of curiosity. So this is about embedding a culture where people feel connected to research. Now, that for some means some individuals will be directly involved in delivering and undertaking research, but for others, they need to have a mechanism to ensure that they and the patients they care for have access to research. So this is about getting the governance and the mechanisms right, but embedding a culture of curiosity and research across the NHS. And I think we've got a long way to go in driving that.
We really do. I've got so many questions coming in, so I'm going to move on so we can get through them. Alison, I'm going to pose this to you. This is from Leslie Keller, who did enjoy your presentation, Kevin. And she wants to wonder, change, including AI, is a constant, and continuity is the glue that helps us to navigate change. But what does that glue look like in the NHS workforce?
I think the glue is currently a bit of a leaky bucket in terms of workforce, and it's one of the reasons I think we have issues adapting to change. So things like AI are part of reality now, and they have been for quite a long time. But one of the things we know about AI is it's only as good as the data that it trains on. And data quality is an issue in the NHS. And one of the things around data quality is having continuity and a common understanding of what terms mean, for example. And when you have a massive churn in the workforce, it becomes very difficult to get that continuity. So for things like AI to embed in the workforce, and particularly in areas like workforce modelling, we'd need a more consistent workforce, and we need to retain what we think of as the proficient workforce. So you need some experts and you need lots of competent people, but primarily to manage risk, you need a proficient, stable workforce. And that's something that is a real challenge right now.
Thank you. Anyone else want to come in on that one? No, okay, I'll move on to the next. So this is really interesting. Teresa Foster asked us, how can we encourage funders to fund more staff wellbeing research? Go for it, Kevin.
Well, I mean, it's one of those things really that it's difficult to answer because it's so obvious, isn't it? That, you know, we spend, what is it, something like 60-65% of the total budget on workforce, that it is our most flexible and adaptive component. And we've seen already in the last 3 years how important it is to adapt to threats that we didn't foresee or prepare for properly. And so, as I said in the talk, it's investment, it's not expenditure, and that's the problem. I think we talk about cultural change, but one of the things that we have done is drawn a false dichotomy between the needs of patient and needs of staff in a resource-limited environment. And whenever there's a choice, we choose the patient because we're patient-centered in our care, and not the staff, when in fact the needs of those two are aligned. And so neglecting one is neglecting the other. And so I think the arguments are crystal clear. When we did the IPPO review, the Institute of Public Policy Observatory review, to see what other evidence there was supporting the need to invest in well-being, I mean, it was overwhelming, but it just seems to have been in the too difficult box for too long, and now is the time to grasp it.
It feels like we've forgotten that staff are patients as well. And I'm speaking at a charity dinner on Saturday for a charity to help doctors who want to kill themselves. And the fact that we have a charity to support doctors who are thinking about doing that in this day and age is horrific. And it brings me on to a question from Susan Walker about moral injury. And she said, a lot of us feel guilty because we can't deliver good care. Now, this was a factor in the pandemic, but it's throughout healthcare where you are under pressure. Can we tackle this with better education and better peer support? Are more honest conversations needed about what life is actually like on the front line?
Yes, I was reminded. So I was just reminded of something Jill Morburn said the other day, that for people to burn out, they must once have been on fire. And I think that's it makes people very vulnerable because they felt so passionate about their work. And I completely agree with what Kevin was saying. We've known since the 1950s the work of people like Abrahams. If you overwork people and take away autonomy around that overwork, they will perform in a much worse way, and they will, cost you a lot of money. Well-being, they'll go off sick, and there's very little in terms of commitment to investment in researching that in healthcare, I think. Yeah,
Mary, you had your hand up.
Yeah, I think this business of moral injury, I don't think Kevin used the term explicitly, but I think that's exactly what he was describing. And this sense that professional people who want to do a professional job are inhibited from doing so is a really important source of challenge for people, and it does result in real harm. And I think there are all kinds of things we can do to support staff to feel valued, well cared for. And some of the really basic things don't happen. The whole debate about AI is being caught up in people saying, well, I can't even boot my computer in the morning. I don't have anywhere to put my lunch. I don't have a locker I can put my bag in. I don't have a badge that works consistently. All that sort of stuff really matters because they're kind of small disruptions and just a feeling that really nobody cares about how you are doing to get through the day. So I think what Alison is describing in terms of peer support, really, really key. And I think a lot of these kind of really mundane but quite important features of everyday life need addressing as well. Something I'd be very keen to hear the comments of the panel on is the whole business of discrimination, bullying, harassment, which I think have structural origins, but also impact hugely on people's experiences of being at work.
Yeah, I mean, Liz, if I may come in. So I think that, Kevin's absolutely right. The patient and the staff are critically important in getting better outcomes. And we have a range of performance metrics around care. We have no performance metrics around well-being of staff. So I think we've got to develop a performance framework to look at well-being. And that's not research. Actually, that's an ongoing surveillance of how well your workforce is. Because we know for a fact that there are 3 things that, enable our workforce to deliver great care. That's, first of all, keep them happy. And that involves all the discrimination and things that Mary's on about. Second thing is avoiding overwork. And the third is making them feel valued. And there is a wealth of research and information out there on those 3 areas. but we fail to turn them into a performance framework. And if we could do that, I think we'd be well on the way to making sure that we can deliver better care.
Brilliant answers. I'm going to move on to the next one now. So Francesca Dakin said she's found that relational coordination, so how people communicate and coordinate tasks in really complex work, like Mary has shown us, and attentional infrastructures, so the values placed on relationships by the leaders, are really important influences of how GP teams navigate change and crisis. Does this ring true in a hospital setting as well?
Look, I would say yes, and I would say that we again draw too much of a dichotomy between primary care and secondary care. It is a continuum of care, and those systems broadly work in the same ways. And I think that the primary care setting is the most adaptable and the most flexible of all of our aspects of the service. It is the point of hard interface between the public and the health service for the greatest part. So yes, I think those relationships are important for us. In the end, I would say this: we are clearly a complex adaptive system. I think that that the relationships are the people in the relationships are the important factor that we have paid little or no attention to. And I just want to make two more points, which is this: that I was reminded of the work, the first work about socio-technical systems from the early 20th century, where long-face coal mining was invented as this way to improve productivity in coal mines, and yet it destroyed the social relationships within teams and therefore led to less productivity. And that analogy seems completely fair with where we've taken our health service. We seem to have lost sight of that component, social relationships, the social structure of it. And I would like to say that what COVID should do, the benefit we should get from COVID, the learning we should get from COVID, it should be a moment for us to stop and pause and say, really, have we structured modern healthcare correctly? Because it is not just the UK that is exhibiting these poor well-being features. Across the entire English-speaking world and the English-speaking literature that you see the same thing, even in better funded systems. So we must ask ourselves that very hard question about whether or not we have structured something that is fundamentally unsustainable, and what we do in the future to pivot towards a more sustainable way of working. I'll let you go. Sorry.
No, second. Carry on. Go on.
I'm just going to finish this point. When I started 25 years ago, it was the end of those Victorian hospitals that we knocked down and put up all the new shiny ones. But in the architecture and design of those hospitals was something that was an acknowledgement that this was a hard job, and you would need the people around you to build a social structure of people around you. And so it had things like social clubs, and it had swimming pools in the nursing homes, and it had a restaurant that was open when you were working at shift work. And all of those things seemed to some people absurd, but actually they were important and people knew it. We have lost that. Thank you.
Yeah. Alison, you wanted to come in.
Yeah, it was really around that point. I think in most safety critical high reliability industries now, the importance of relational labour is actually factored into workforce planning. So they have a more humanistic approach to workforce planning, whereas I think healthcare is still very much on demand and capacity. It's still around, how many people do you need to deliver X activity. And I think, we do need a bit of a cultural shift to accept that healthcare is something done by humans to humans. And I'm not even a social scientist, and I understand this,
It's really important, isn't it? Now, Kiran, I thought you could answer this one. Nadine Al-Jandali asked, how much of the voice of nurses being factored into the solution in very senior settings, such as at an operational and legislational level?
Yeah, so I think, we have to start by saying that healthcare is a people business and everybody contributes equally to that. I think we prey on the fact that we try to find differences. So we have a lot of professional sovereignty, sectoral sovereignty between primary and secondary care, and organizational or geographical sovereignty. So we thrive on trying to be different, whereas the reality is we are much more similar than we are different. And therefore the patient care we need to deliver is very similar across the country. And we should stop wasting time trying to find why we're different. Find what works. Some of that is behavioral interrelationships, as we've just commented on. And some of it is saying, let's look around us, let's look at where gets great outcomes, and let's just plagiarize and learn from each other. Be proud about it. You know, the N in the NHS stands for national, so let's look at what is national and standardized and do it well.
Stop trying to reinvent the wheel and just copy and replicate. And I also think the voice of the tea fairy should be included. The ladies and men who go around delivering tea often see the patients and they really know what's going on. Everyone should be able to give their input into how we can make things better. Quick one for Kevin from Carol Sinnott. Do we know what the PTSD rates in the general population were at those time points?
So we do know that they were much higher than they would have been in outside of COVID. The PTSD rates general population like 3%, 2 to 3%. And I should be clear for all the psychologists on the call screaming that it was a screening tool and the diagnostic rates will be much lower. Yeah. But the statement that it is comparable to British military veterans is reasonable, and you know that should be paused for all of us. And so yes, everyone was under pressure and exhibited higher rates of mental health symptoms during COVID. But actually, I think the important thing is that it was one of the few longitudinal measuring tools to even try and measure well-being during COVID. And none of that was factored into how we should be managing the strategy of the management of COVID. Now, that is, I think, a little sort of potted portrait of where we are with the service as a whole.
Thank you very much. So this is one maybe for Mary and Alison. Jan van der Scheer asked, what does good look like for measuring well-being? For example, with a view on use in regulatory frameworks, do we need like a little pain score with a caricature? Will it just be a minimal well-being score for clinicians that doesn't mean anything?
I can see what we do in other industries. So in other industries, we use pulse surveys and things like that quite a lot to take the temperature of an organisation. Including things like intention to leave. Now, intention to leave is not, people always overestimate intention to leave virtually. It was quite interesting that we've run these surveys quite often for about 15 years. And in healthcare, they always ran at about 20% and the leavers rate was around 5%. And then in May 2021, they jumped to 60% intention to leave. And it hasn't come down. Wow. Which is, and obviously we're seeing quite a lot of churn as well. So I think there is definitely something in it. There are a lot of established tools for looking at. I think Mary made a really good point the other day about the term well-being being toxified now. So certainly we look at people's emotional health and their experience of work, because quite often that is a good indicator of you know, the temperature of an organisation. In terms of putting it into a framework, it would normally be in terms of a regulatory framework for safety overall. And healthcare doesn't have an overarching safety regulator, so it's a little difficult in that sense.
Thank you. Mary?
And I'll just pick up from there to make a slightly different point. I think Alison has covered the measurement end of things well, and there are kind of proxy indicators we can look at as well. One of the highest predictors, for example, of essentially staff churn and well-being is the extent to which they would recommend the place where they work to their friends and family. That's actually quite diagnostic, and you can also look at turnover rates. But I think there is something very important about what Kiran has just said, and that is a feature of the discussion Kevin has been leading on AI, which is the roles that we're going to need. It's quite clear the roles we have now are their guilds to some extent, that they have medieval origins, and I'm not sure they're going to be fit for the future. We're seeing an awful lot of challenge about the emergence of new roles and how they fit into this world we are moving into. And to Alison's point, we don't necessarily have a national place to have that debate, because there isn't a national regulator for healthcare. There are policymakers whose interests are not always fully aligned with those of others, and they're essentially professional guilds that are very concerned with defending their own boundaries. So as AI begins to join the team, as it were, where do we go with this, and what is the impact on well-being as people begin to feel that their roles are being eroded, that their autonomy is being challenged, and so on? I'd be very interested in Kevin's thinking about what's how we even begin to plan for some of this.
But before you come Before you come to that, Kevin, we've got about 2 or 3 minutes left. This has come in. We have the robot question. What is your prediction for the situation where robots are currently being used as surgical devices? Are they going to undertake more healthcare roles? How far into the future?
Look, the way we use robots in surgery is effectively as a tool that smooths out the difference between intention and performance. You have that everywhere in your life. Your car does that. Your car does so much interpreting of what you do and works out the difference between what you want to do and what you actually are do. So I think that's here and that's going to stay, and that's good. Mary's point about the way it erodes people, there is a danger here, isn't there, as AI joins the team, as Mary says, and it's going to join it in an unpredictable way. That's why co-creation is so important. That's why going forwards as it comes, we need to involve the people who have most to gain and lose by it. And we don't have mechanisms for doing that at the moment. And as I said, this is all very, very unpredictable. So it's unclear how that will happen. Most of the problems we're seeing, to Mary's point about the introduction of new roles within the workforce, is not those roles themselves, it's the absence of co-creation in that. It's very poor delivery. Thank you.
Brilliant. Final question now. Can any of the panel share examples of initiatives in the NHS that have addressed well-being and successfully improved retention? Are there any out there?
I'll very briefly kick off this. I think there are some out there. Certainly at our trust, we did surveys of what makes people feel valued at junior doctor and consultant level and turn those into an action plan. So we work on the non-fiscal elements of making people feel valued.
Brilliant. Anyone else, any initiatives they know of?
And although, sorry, Alison, you go for it.
No, it's okay. I was just going to mention Schwartz rounds, actually, because Schwartz rounds have been shown to really help people with the emotional burden of work, and also inclusivity. So where issues around the built environment or other issues around the experience of work have included all work groups. You know, the porters, the people that actually do a lot of the work is done, as we think about. There have been some improvements in terms of retention.
Thank you. Kevin?
I need to say, I mean, in my own trust, I think they've been quite forward-looking in this regard. In their strategic priorities, it's included only second only to patient care, I think, itself as the priority for the trust, and that was reflected in our most recent wellbeing survey. We scored very highly. So you can make it a priority and you can make a difference.
Brilliant. Well, thank you so much. I hate to leave this there. It's been such an extremely lively chat. There's about another 10 or 15 questions. So remember, you can ask them this afternoon in the Meet the Speakers chat from 12:30. Thank you so much, panel. You've been absolutely brilliant. Thank you.